On to Dr. Sourabh Patwardhan, who's again one of those rarest of rare surgical genius who actually believes that one evolves better as he continues to better his brethren. And I think if we can go through his brief, you know that he's been doing a whole lot of phaco training programs, and he has another amazing pearl for us here. On to you, Dr. Sourabh. Dr. Sourabh, are you there?
Yeah, thank you, ma'am. I'm trying to share the video. Just okay. Just give me one moment because I think the sharing enabled.
No, not yet.
I'm not getting the option of sharing the video.
Share screen. It's not there on your thing.
Share screen is there. Should I share the screen?
Yeah, just share screen, sir.
Okay, okay.
It's coming on.
Fine. Can you see now?
Yes, yes.
Yeah. So I'm sharing a pearl about the anterior CCC in a congenital cataract, because when I started doing the congenital cataracts, I thought how it is different from adult cataract, that I have to do just posterior capsular axis in these patients, which is different. But I think the most difficult part of congenital cataract is not in fact the posterior CCC, but it is the anterior CCC. Hello, I am Dr. Sourabh Patwardhan from Nandadip Eye Hospital, Sangli, India, and phaco Training Center. And in this video, I'll be speaking about CCC in congenital cataract. In pediatric eyes, the anterior capsule is highly elastic. Once we make a small tear in the anterior capsule, there is a tendency of this tear to go out because of the elasticity of the capsule and because the zonules are very strong and the sclera is also quite elastic. So doing anticapsular CCC in congenital cataract is more like tightrope walking, where you have to keep on balancing the forces. So let's have a look at the steps. So for congenital cataract, I use two side ports for the manuring, and I always stain the anterior capsule with trypan blue, which improves the visibility. Also, it will make the capsule little bit more fragile so that it reduces its elasticity a little bit. Once the dye is washed off by BSS, I inject 1.8% hyaluronate. This is my OVD of choice for congenital cataract. We can also use Helon 5. And once this is injected well in the anterior chamber and chamber is formed well, we start off with making the first nick right at the center of the capsule here. So I generally use a 26 gauge cystitome for doing this. After this, I shift to microcapsular axis forceps for the next steps. It gives me much better control over the capsular tear. We use two specific movements. One is the centripetal and second is the tangential force, which I will explain in detail. And before we start, we have to imagine what is the exact size of CCC that we want. We can also use a CCC marker over the cornea. Now just watch here carefully how the capsular axis forceps is being used. Here I am pulling the tear centripetally fully. And with this centripetal pull, I try to keep the size of the CCC within the limits. So I keep pulling the tear centrally, and now I will give very mild tangential stroke. Remember, this has to be very delicate tangential movement. Just watch here in slow motion, just little bit tangential movement outward, and this much is enough to achieve the larger size of the CCC as needed. And immediately I shift again to the centripetal pull. Whenever I feel the CCC is going smaller, I give very soft tangential stroke. It is very important to be very delicate, and we should give very mild tangential force, otherwise it will just go out. So as you see here, the anterior CCC in case of congenital cataract is the balance between the centripetal pull and the very controlled tangential stroke to achieve the right size of CCC. For more such videos on phaco training, you can subscribe my YouTube. Also, you can visit our website phaco training.
Thank you.
Thank you.
Saurabh. That was a wonderful teaching, Pearl. Um, just an information. This is the standard way of doing a rexus in these elastic capsules. What is your experience about the push-pull technique, which is also alternately measured when mentioned when you do pediatric cataract? Is there a difference in these two which you would want to point out?
Which is the other technique, push pull, making the two nicks, and then
Yes, yes.
I have not, I have no experience. I think maybe Dr. Love can tell more about it.
Anything to add at this point?
I think great teaching video, Saurabh, by you, and I think you've mastered the way to tell others and do it yourself, of course, and to tell others, which is very important. I've also seen your video on the law of that triangles thing on capsulorhexis. That video is also very good. In pediatric cataracts, it's always like this. When you want to do a anterior capsulorhexis, it is always larger than what you desire to do because it will keep extending. And for posterior capsulorhexis, whatever you aim for, it tends to be smaller than what you want. So I think very beautifully explained. There is nothing extra to offer from what Saurabh has told us. Excellent.
Push pull has been
Video,
described
wonderful
by
video, Saurabh. I mean, just a point to add, you so nicely showed the centripetal movement. I feel it's not only centripetal, it's also the push should be towards the apex of the cornea, not only pulling it inside, but also towards the a little upwards. I feel that that gives a little better control. And though this was not an intumescent cataract and you have excellent surgical hands, don't you think that once you had a reasonable opening, if you had decompressed the bag a little, then you would have even better, it would have been an easier rexus?
So my experience with intumescent cataract in children is that usually when we try to aspirate, it's a dry tap. So generally, in my small experience, I feel that it doesn't help. In adults, intumescent cataract, I think aspiration is helps. But in pediatric, I felt that it was not that useful.
And what do you feel about this inward movement and towards the corneal apex? Do you do that or do you just pull in?
I think the choice of OVD is very important. I think the earlier mistake I used to make was that I used to use 1% or 1.4% hyaluronate, and it used to keep the anterior capsule little bit convex. And for that, I think for those cases, I think your point is absolutely useful, where the direction has to be towards the apex. I will try it in the next case. But since I am using the 1.8% hyaluronate, which is much heavier than the 1% or 1.4%, it keeps the anterior capsule very flat. So the movement is usually towards the center of the lens rather than towards the cornea.
Very nicely demonstrated, Dr. Sourabh. Just one more, of course, the principle is you always use a tear technique. You can never use a shear technique in pediatric cataracts. I mean, when is the situation when you would use a bimanual capsulorhexis?
Bimanual for the pediatric cataract?
Yeah, for the pediatric cataract.
I think where the zonules are weak, sometimes we may have to use the bimanual way too.
And also when it's kind of running out, I think if you actually put a little pressure on the periphery, then you can get it back much easier. So whenever there is zonulopathy or when it's kind of getting out of your imaginary boundary, then you use a second instrument and then put a little pressure at the area where it's tearing, and then you can bring it in easier. I think these are a few points. Otherwise, excellently demonstrated. Very nice video.
Thank you. So one more observation, that when there is actually zonular weakness, like in case of Marfan's, the CCC doesn't run away even in pediatric.
Yeah, CCC does not run away
Because there is no.
But it is difficult to do a tear. See, when you have zonulopathy, it is difficult to do a tear, and basically there is no adequate counter traction. So to provide the counter traction, you use the second instrument to provide the counter traction on the capsule and then pull it.
Thank you.
Is anybody has used Vitrector, like Vitrectorex is what they say, for the anterior capsule? Has anybody tried it from
In
the
fact,
panel?
when I started out doing congenital cataract, because I am basically started as a retina surgeon, it was very easy for me to use. And in fact, it used to be very easy congenital cataract surgery, because you start with vitrectomy and you finish off everything with the vitrectomy probe. I think that is a very easy technique to master as compared to the CCC using the manual technique. But I don't know the long-term results. I later learned this after seeing the pediatric ophthalmologist videos.
Well, even if you use a Vitrector, what happens is you get a circular rexis only.
Right. I had a patient who was 2 months old a few years ago, and the capsule also was a little fibrosed. So I had used at that time, gave good results.
The only difference in Vitrectorexis is you have to keep the vacuum high and cutting low. Otherwise,
Yes.
Yeah.
Yes.
pretty much the same.
Thank you very much, Dr. Sourabh.